to our symposium on suicide prevention. We're going to continue with our session in the afternoon. I'm Miguel Hernán. I'm the director of the CAUSALab. Thank you all for being here. And we are going to continue with the presentation by Dr. Philip Wang, who is a professor at Harvard Medical School and the director of the new Center for Learning Health Systems at the Brigham and Women's Hospital. And Phil is going to talk to us about what's next in research for suicide prevention and why it hasn't been done yet. So,
Good afternoon, and it's really a pleasure for me to be able to present here. I get to get back together with just about everybody that I trained with. Miguel, you and I were in grad school together, and Matt and Kate and Ron. Ron's still here, but you know, folks that I've just had the privilege of learning so much from. So anything I say that is good and worthy, I've learned from them. Anything that is just awful, well, you can blame me. I get the enviable task of projecting, looking into a crystal ball and saying, in terms of suicide prevention, what's next and what are the challenges and reasons why it hasn't been done yet? So before COVID, suicide rates in the US were rising, as you can see, and they weren't in a lot of other countries, so it's not something global. They also weren't rising for a number of other forms of death, cancer, diabetes, heart disease, stroke, all of which had substantial declines, showing that there are ways to intervene. So some of the reasons have to do with the challenges in predicting and preventing suicide, which the other expert presenters have already covered. One is suicide is a very uncommon event, even though it's a very problematic and fatal event. It is a result of numerous factors, complex interactions, which are hard to tease apart in traditional data sets. And as Matt, I think, eloquently pointed out, you know, the risk varies greatly over time. And if you aren't able to assess that risk temporally proximate to, you know, sort of an event or to your ability to intervene, that's really not very good. So how can we actually do suicide research better? And one way is through measurement-based care. And what is measurement-based care? Well, I used to be here at Harvard, and then I left 20 years ago. And I got a day job at NIH. And I also got a weekend job coaching elementary school girls basketball. And there was a couple that joined at the same time, and they got day jobs as a FLOTUS and a POTUS. And this POTUS fellow, and the FLOTUS, by the way, is a lot smarter than the POTUS, to be honest, and he's pretty damn smart. But anyway, they both seem to know an awful lot about measurement-based care, as typified by this quote that was in a speech he gave very early in his presidency to the AMA. And he lamented, he said, we do a better job tracking a FedEx package in this country than we do tracking patients' health. We need to give doctors bonuses for good health outcomes, so we're not just promoting more treatment, but better care. And that really typifies what the problem is, certainly in mental health care. Oh, and in case you're wondering what the provenance of this photo is, so the White House released 100 photos for Obama's first 100 days. So there are 99 photos that they released, and they're of him with the head of state signing some executive order in the Oval Office. And then this was the 100th photo they released. And so it's very, very good spotter as in addition, Matt, to being a used car salesman, I also learned at NIH to be a good spotter of talent because I can't do anything. I only can get things done by finding other people who can. And it's great. So I invited this POTUS fellow to actually co-coach and whip these girls into shape. I mean, before I had said, listen, why don't you just mill around and have fun? And so they would all 10, I don't know if any of you have coached girls basketball, but they just, there's 10 girls all milling around the ball. Well, he sort of, he took them to in the middle of the Cooper building, which you think can withstand a nuclear device. There's actually an inner sanctum is a basketball court. And so we practiced there and we invited Reggie Love, his pupil All-American, and a Mystic Star. And they essentially taught the girls to play a position, pick and roll, and the rest of the league didn't know what to do with us after that. And our star was actually President Biden's granddaughter. Anyway, I learned an awful lot about learning health systems too. And what they're typified by, again, this quote that Obama gave to the AMA. We need to continually evaluate how we can eliminate waste, reduce costs, and improve quality. We need to figure out what works and encourage rapid implementation of what works in your practice. So, how can we stand up measurement-based care and learning health systems? Well, we're very grateful to my former employer, NIMH, for giving us 2 grants. One is an NIMH Alacrity Center grant together with Ben Cook, my superstar co-PI, and I think Matt, you're on it, and Ron, and a lot of people are on it. And its goal is to establish a learning health community outside the clinic walls in the diverse neighborhoods surrounding CHA. That's Community Points, where I used to be, although we're still working on this grant together. Within the clinic walls, we will establish a fully integrated learning healthcare system. And I'll explain a little bit more about what that entails. We also hope to stand up measurement-based care and learning health systems by expanding the digital knowledge base that is already available in many healthcare systems like CHA, like Mass General Brigham, where I am now. But we want to add ground truth, and I'll explain what that is. In this case, in mental health, it's patient-reported outcomes, which are collected not for research, but for routine practice. We also want to expand the structured data using natural language processing of physician notes and RN notes. And in the case of MGB, where I am, there are literally millions. You have millions of these free text notes from which you can pull structured data. We also want to merge EHR data with claims and other extant databases. In this case, via geocoding, neighborhood level social determinants of health. CHA has school clinics, so we have school data from schools on students. We also have criminal justice data because of some data use agreements with, for example, the police. We also want to deploy advanced methodology. These are methods that CAUSALab, is in the process of developing and already has developed. And we want to train personnel. And Frankie is, maybe she's not here, but we're very lucky. Miguel and Matt and I, we're very fortunate to receive a T32, and Frankie is our inaugural pre-doctoral fellow. Yes. So thank you. So in terms of measurement-based care, it starts with collecting what's called ground truth and on mental health, substance use disorders, and social determinants of health. And in this case, using a computerized adaptive testing platform called CATMH or KCAT for youth. These are, firstly, in terms of ground truth, that's a term my former boss, Tom Insel, used to refer to lament what is not being collected in mental health care. Fewer than as few as 15% of clinicians measure anything related to mental health. And it's largely primary care clinicians measuring things like PHQ-9s, PHQ-7s. Mental health specialists don't measure anything, literally. That's a major problem. So we were very fortunate to receive, and then we were grateful to fund the development of CADMH and KCAT. Robert Gibbons is the biostatistician you see on the right-hand side, and it uses multidimensional item response theory. I'm not going to go through what exactly it measures, other than to focus on two modules. One is the suicide module, and it was just tested in the VA. And it was shown that compared to the highest scores, compared to the lowest scores, the highest scores on the suicide module predicted an 8-fold increased risk of an imminent serious suicide attempt. So highly actionable. Okay. And then the other is we have a research project going with them to develop a social determinants of health module, which as this group needs no introduction to. And social determinants of health, determine the majority of the variance in mental health outcomes. And so if you're not measuring the presence and severity of them, you've got a lot of unexplained variance. We started standing it up. One is we started administering CADMH, KCAT. We also have been interested in collecting the HUDAS. This is a basic measure of functioning, which is very important, obviously, as well, to collect if you're going to do measurement-based care. Doing it in community samples, we were lucky we got an NCCIH supplement to screen in general population samples, and refer people, if they were mild or moderate, to a wellness prevention program called CHA MindWell. They recommend lifestyle interventions, some evidence-based apps, ICD-CBT, which you heard about, virtual groups, mindfulness-based stress reduction, and mindfulness-based cognitive therapy. It can also be used, and we're exploring this in MGB, in primary care to screen and monitor. It can also be used at central intake into mental health specialty care, where you can do rapid data-driven triage. In this case, we've been exploring it for a comprehensive disease management program that some of you may be familiar with, a very strong evidence-based one called collaborative care, but it's just for depression. And we believe the principles by which it would decrease symptoms, improve functioning, and also mitigate disparities would also hold if you were doing disease management across mental health and substance use disorders. It can be used, and we've been piloting it, measurement and team-based psychiatry, both on the inpatient and outpatient side. And more importantly, for suicide, the subject of this, you can also rapidly refer people who have a high suicide risk straight to the ED. Or let's just say they have high acuity, where you could send them, there's a same-day service for evaluations at the Brigham, or disease-specific clinics, first episode psychosis, addictions, complex PTSD for people who have high PTSD scores, and evidence of trauma. You can then use this. This is called a deep learning health system to conduct rapid forward and reverse translation. And it basically you take what's in the EHR, demographic, personal, clinical data, ask clinical decisions and outcomes, which you can get from these natural language process pretext notes. You add longitudinal measurements of ground truth, and now you are able to use machine learning, other artificial intelligence techniques to essentially develop and evaluate computer-aided diagnostic and risk assessment algorithms. And you can start presenting these to clinicians in real time via clinical decision support rules that show up in your screen. In other words, someone scores high, well, you get this thing saying, gee, this person has a high suicide module score, maybe you should send them to the emergency room, something like that. So I'll give you examples of each of these. So This is what I meant by using longitudinal measurements of ground truth to inform. You can use them to develop clinical innovations, insights, which you then test in the form of these clinical decision support rules. So again, this is like a screen that pops up and advises the clinician to do something, right? And so this is the sort of just-in-time intervention that Matt was describing. And again, you do this via hopefully visually understandable. Like you don't want to bury this in a ream of articles, right? You literally want to show the person's scores over time and say, this is why we are recommending this. Oh, and by the way, here's a paper that suggests that this is the best thing to do. You can conduct additional rapid forward translation, very much akin to what you were hearing before. In terms of, you can start adding additional dimensions of data to the digital knowledge base, one that we've been very interested in for the reasons that the predictive value that Matt covered. We've been very interested in adding actigraphy and physiologic measures, heart rate variability, temperature, because they've already been shown to be predictive, right? And these could be collected via passive monitor, Fitbit, it could be your smartphone, you name it. And then again, you subject these to artificial intelligence analyses, come up with clinical decision support rules, present them via shared visualization tools. Practical example would be providing staff with support tools to select interventions, assigning increased risks, increased checks for inpatients, or maybe one-to-one sitters, for someone very high risk, or triaging to a higher level of care. So I'll close with this last example. You can also use a deep learning health system to do rapid reverse translation. And this is a project that's part of our alacrity grant that Matt and Ron are already advising us on. It's being led by Nick Carson. He's just terrific, child and adolescent psychiatrist who's also a suicide researcher. And what he's using is digital, the digital knowledge base on existing treatments in one of the R34s to study the real world effectiveness of mental health interventions for suicide prevention in at-risk youth. Essentially what it starts with is collecting, again, this information-rich longitudinal covariate data, in this case, CAT-MH, KCAT, UDAS, which tells you someone's clinical diagnosis, symptoms, their functioning over time, as well as their social determinants of health, which, you can imagine these temporally can be very related to suicide risk. You lose your job, housing insecure, you probably are very, very high risk. And then using statistical analysis, estimating via propensity scores, exposures, in this case, like Gonzalo, what you were looking at, in terms of medications, you actually can hopefully get unbiased estimates of the impact of the medication, after adjusting for these clinical covariates. And in that way, identify potential treatments that may be, ways to treat suicide, or ideally actually prevent suicide. And ultimately, we would like to, after identifying candidates, actually test them in stratified trials. So let me stop there.